Ladies and gentlemen, good morning. Good morning, dear colleague, dear patient. My name is Marc Possover. I'm the founder of the Neuropelveology, and I'm a strong believer on patient education in neuropelveology. And today we will have a talk on a very interesting, very important topic, the pathology of the pudendal nerve, which is coming more and more in focus in gynecology, and in neuropelveology. And for that, we have to understand a little bit more what is pudendal pain or what is the pudendal nerve. So once again, we have always, in neuropelveology, we have always to come back to pelvic neuroanatomy. We have to understand the nerves, the location and the function of the nerve. We are all talking about the pudendal nerve, but in reality, the pudendal nerve emerges from what we call the sacral nerve roots. That means from the spinal cord, the sacral nerve roots emerge from the spinal cord. They are passing through what we call the sacral foramen, small hole in the sacrum, and then they come inside the pelvic cavity. And from the sacral nerve root, from the sacral nerve root S2, S3, and S4, the pudendal nerve will develop. Then the different fiber will fusion together and will build an intrapelvic portion of the pudendal nerve. This pudendal nerve, this portion of the intrapelvic portion of the pudendal nerve is within the pelvic cavity, directly behind the sciatic nerve. From there, the nerve will pass through what we call the less sciatic foramen, is above the sacrospinous ligament, and then will re-enter inside the pelvis, but below the pelvic floor, at the level of what we call the Alcock canal. And there we are at the level of the infrapelvic portion of the pudendal nerve. So you see the pudendal nerve, or the pathology of the pudendal nerve fibers, can occur at the level of the sacral plexus, at the level of the pudendal nerve above the pelvic floor and inside the pelvic cavity, or below the pelvic floor. And what we call the Alcock canal syndrome is the pathology of the pudendal nerve below the pelvic floor, and by the through outside the pelvic cavity. The pudendal nerve is what we call a somatic nerve. That means the pudendal nerve has both functions, to bring sensory function to the brain and to bring motor function from the brain to the periphery. The motor function, the main motor function of the pudendal nerve is to control the external sphincter of the urethra and of the rectum. That means control the continence of the bladder and the rectum, and have some activity, of course, in sexual function. Secondly, the pudendal nerve will bring feelings, sensation to the brain, the feeling from the external genital area, that means the genital area plus what we call the perineum, plus the perianal area. The perineum is between the perianal area and the genital area. And of course, once again, have some activity in autonomic function of the pelvic organ and is involved in sexual function in men and in women. So the classical symptom from the pathology of the pudendal nerve, it's burning pain. When we are talking from the pathology of the pudendal nerve above or below the pelvic floor, not at the level of the sacral nerve root, but a pathology of the main trunk, the main nerve of the pudendal nerve, the pain will feel burning pain, a sharp pain, a pain mostly somewhere between 6, 7, and 10 on a scale from 0 to 10. 0 is no pain, 10 is the worst pain ever. In all three areas together, the genital, the perineal, and the perianal area, the pain will occur while sitting because the pudendal nerve will be compressed between different ligaments, what we call the sacrospinal and sacrotuberal ligament, with a pain relief once the patient is standing up or lying. And very, very important, when you have a pathology of the pudendal nerve, there is no radiation of the pain in the lower back, in the buttock, or in the leg. While if you're talking from the pathology of the pudendal fibers within the sacral plexus, because the sacral nervus S2 contain sciatic fibers, in this situation, the patient will combine a pudendal pain with sciatic pain, lower back pain, or buttock pain. And because S2 is just in charge of the perianal area, mostly this patient will not present the full pain from the genital, perineal, and perianal, but just the perineal pain. Now, motor dysfunction, yes, in situation of lesion of the nerve, the patient will develop some trouble with sexual function, trouble loss of erection, for example, or for the bladder and the rectum, urinary and fecal incontinence. But in this situation, patient need to have a lesion of the pudendal nerve on both sides. Usually one side pudendal nerve lesion is not enough to induce incontinence so far the other nerve on the contralateral side is healthy. So the key in pudendal nerve is to understand if we're talking from a pathology above or below. And when we see a little bit in the literature, all the paper, all the literature will talk about the Alcock canal syndrome. So that means we have good data about the prevalence of the pudendal neuralgia below the pelvic floor, and is between 1 and 5 patients in 100 people annually. But we have no data about the prevalence of pudendal neuralgia above the pelvic floor, within the pelvic cavity, because for several years, this pathology, this condition was not known. We were not aware that pathology of the pudendal nerve above the pelvic floor does exist. And that for the simple reason that the pathology of the pudendal nerve, the Alcock canal syndrome, has been discovered and developed by neurosurgeons. And neurosurgeons are trained in surgery outside the pelvic cavity. So neurosurgeons are coming from below or from behind, but not from above. And for pathology of the pudendal nerve within the pelvic cavity, we have to come from above. And for many years, I wrote a paper on the laparoscopic management of endopelvic pudendal neuralgia. And in a series of 134 consecutive patients who were sent to me for management of an Alcock canal, more or less 130 patients, 120, so the large majority of these patients were suffering not from a pathology of the pudendal nerve below the pelvic floor, an Alcock canal, but above the pelvic floor, within the pelvic cavity. So the diagnosis, how to make the diagnosis. The first is the patient history. The patient history, because patient need to have a cause to develop a pudendal neuralgia. A pudendal neuralgia will never develop out of the blue. You need a cause for that. Secondly, of course, we are a neuropelveologist, most of us who are gynecologists, so we have the capability to bring our fingers through the vagina or immense through the rectum to the pudendal nerve above and below the pelvic floor. And that once again, that will be the key in the diagnosis, and which will induce directly the treatment. The treatment will depend from this question. We're talking from pudendal neuralgia above or below. Of course, we can do nerve conduction study and EMG, but to be honest, I'm not doing that in my daily activity for a simple reason that any pathology of the pelvic floor or any vaginal delivery will induce some change in this electrophysiological study. So nerve condition will change after simple vaginal delivery. So difficult to trust. And imaging MRI or CT scan can be helpful to exclude a pathology like a tumor, eventually an endometriosis, so far the radiologist is trained in this pathology. Then, after the patient history and the vaginal examination of the pudendal nerve above and below the pelvic floor, the next very important point for diagnosis will be pudendal nerve block injection with a S, because you can do a pudendal block below and above, and that can be very, very helpfully to make the diagnosis of the localization of the pathology of the pudendal nerve. And usually we say that the pudendal block is positive when we are able to induce a pain relief for more than 50% for maybe 1 or 2 hours. So the cause, I mentioned before, to develop a pudendal neuralgia, you need a cause. You need a cause that means something in your life has happened and induced a pathology of the pudendal nerve. And of course, everybody knows that a professional cyclist, because of prolonged pressure on the pudendal nerve of the bicycle, will develop or can develop a pudendal neuralgia. 30% of the cyclists after the Tour de France will develop such kind of pudendal pain. Most of the situation, it will resolve from alone. Then we have in gynecology a typical procedure called the Amraj-Richter procedure. It's a surgery done by vaginal approach, where we're fixing the vaginal cuff to the sacrospinal ligament in situation of prolapse of the vaginal cuff after hysterectomy. And because the pudendal nerve is just behind the sacrospinous ligament, sometimes we are bringing a suture on the nerve that will induce a pain the day after the procedure. In this situation, the best is really to cut this suture as soon as possible before irreversible damage of the nerve will occur. So to get pain while sitting after Amraj-Richter procedure is more or less normal. But if you develop an incredible burning pain directly after the procedure, better to release the nerve by simply cutting the nerve again. But the main cause of Alcock canal syndrome is the vaginal delivery. And that's the reason why most of the patients affected by pudendal neuralgia are women. But not every vaginal delivery will induce a pathology of the pudendal nerve. You need some risk factors. You need a risk factor like forceps extraction, vacuum extraction, baby with more than 4 kilograms. You need a big episiotomy. You need an hematoma or an infection of the episiotomy after the delivery. So just to develop an Alcock canal after a normal vaginal delivery, that is very, very uncommon. Now, very, very important to mention that such an Alcock canal or pathology of the pudendal nerve after a complicated delivery mostly don't appear directly after the vaginal delivery, but usually years or decades after the vaginal delivery. And in my daily activity, most of the patients I see with a true Alcock canal secondary to a complicated delivery develop the pain once they are becoming postmenopause. That means around 50. For a simple reason, the estrogen level are decreasing. That means the tissue of the whole body are losing the elasticity. And if the patient, because of the completed vaginal delivery, develops some scar tissue around the pudendal nerve, once they are becoming postmenopausal, this scar tissue will start to compress, to untripe, to tie the nerve. So be aware, once again, Alcock canal can develop even 30 years after a complicated vaginal delivery. So the argumentation to say, wow, the delivery was for 20 years, nothing to do with the vaginal delivery, that is definitively not an argument. So now, intrapelvic cause. The cause of pathology of the pudendal nerve above the pelvic floor are completely different. And one is endometriosis. It's true that an endometriosis at the sacral nerve root, a deep infiltrating endometriosis coming from what we call the rectovaginal space, can grow laterally and affect the sacral nerve root and induce pudendal pain. In such a situation, the pudendal pain is usually incomplete. It's not a burning pain from the vulva plus perineum plus perianal. Usually it's just the vulva or just the perineum and just the perianal area, plus some pain in the sacral dermatome, mean lower back pain, buttock pain, sciatic pain, plus some trouble with especially the bladder function, with hypersensitivity of the bladder. Of course, pelvic surgery, radiotherapy, traumatism, pelvic traumas can induce a pathology of the pudendal nerve above the pelvic floor. Usually, it's not an isolated pathology of the pudendal nerve. It's always more or less in combination with injury of other nerve. And you remember I told you that the pudendal nerve and the sciatic nerve are very close. So usually patients have sciatic pain plus pudendal nerve. But that is quite seldom because most of the pelvic surgeons are really not going in the area of the pudendal nerve. So in this situation, the main cause is not a directly lesion of the nerve by the surgeon, but more a secondary irritation of the nerve due to an inflammation or postoperative hematoma that over time will develop scar tissue and tie the nerve. Of course, genital perineal surgery, especially with hematoma, infection at the level of the paravaginal tissue, may induce pathology of the pudendal nerve. And in this situation, is usually below and above. So suppose you develop an hematoma due to the episiotomy at the Alcock canal area. Usually this blood will follow the nerve up to the supralevator area of the pudendal nerve, so the patient will develop pain in both areas. So pelvic embolization, especially when the device used for the embolization is compressing the nerve, that is something we see more and more. We have some very certain tumor of the pudendal nerve called schwannoma or compression by lipome, but probably the most frequent cause for intrapelvic pathology of the pudendal nerve is the vascular entrapment. Because anatomically, when the pudendal nerve is leaving the pelvic cavity above the pelvic floor, you will find the pudendal nerve and usually one arteria and two veins passing through what we call the left sciatic foramen. And this foramen is very, very narrow. So if the vessels which are in direct contact to the nerve are too big, for example, in case of pelvic varicose vein, in the situation on an Ehlers-Danlos syndrome, then the patient will start to develop a pudendal pain. And typically, all situations that will increase the blood pressure will increase the pain, mean the men's bleeding, mean sitting for a while, standing for a while the lying position will decrease the blood pressure and the patient will experience much less pain. So treatment option for pathology of the pudendal nerve is directly depending from the location. above, below, once again. So below the pelvic floor, what we call the Alcock canal syndrome, of course, you have technique of surgical decompression. Roger Robert in Nantes developed the transgluteal approach. It's an easy surgery. It takes more or less 20 minutes and you can decompress the nerve, but this is a surgery. And in my experience in the last 15 years is that in most of the case, you can try Botox infiltration if the block with a local anesthesia was successfully. And the idea is not to block the nerve just for 6 months and to repeat this Botox infiltration every 6 months for the rest of your life. But the idea is to train your brain to forget the pain. So in my experience, it's usually necessary to repeat the Botox infiltration maybe 2 or 3 times, and that's it. Now, if you are talking from pathology of the pudendal nerve above the pelvic floor, then you cannot use Botox because remember, I told you that the sciatic nerve and the pudendal nerve are very close together. That means if you try to inject Botox to the pudendal nerve above the pelvic floor, you will block the pudendal nerve for 6 months, 9 months, but you will block the sciatic nerve as well. And you cannot do that. You will develop difficulty for walking. And close to the pudendal nerve and to the sciatic nerve, you have the pelvic splanchnic nerve, which are in charge of the voiding function of the bladder and the rectum. So if you use Botox, you have the risk to not be able to void your bladder on the rectum. You will develop chronic constipation, or even will need to use a catheter to void your bladder. So once again, that is the key, above and below. And when we are above, the main technique is a laparoscopic exploration decompression of the pudendal nerve. To climb from below is very difficult because below you will not be able to enter the pelvic cavity. And suppose you try a transgluteal neurolysis of the pudendal nerve in situation of vascular entrapment, and you have a bleeding, you have a lesion of the vessel, then it can become very, very tricky. It's extremely dangerous. But such pudendal vein, when you have a bleeding, can really expose the patient to extremely severe complication, even death. So if you want to make a decompression of the nerve above the pelvic floor, you have to come from above, and you cannot do that by open surgery. You have to do a laparoscopic approach. And that is really a surgery that requires a lot of experience. Even if you're able to expose the nerve to make dissection of the nerve by laparoscopic or robotic surgery on cadaver dissection, that don't mean you are able to do that by laparoscopy. It takes years of experience to be able to do this procedure, even more because you cannot simply resect, close, transect the vessels, because the pudendal vessels are in charge of the sexuality. If you do a laparoscopic exploration decompression of the pudendal nerve for vascular entrapment in a man, and you come of the idea to transect, to close the vessel, the patient will simply lose the capability of erection. So you cannot do that. So you have to release the nerve, you have to cut as less as possible part of the sacrospinous ligament, but you have to preserve the vessel. And that makes this procedure very, very difficult, requiring a lot of experience in laparoscopic neuropelveological procedure, some knowledge in vascular surgery, and in any case, a time to do it. It requires, once again, a lot of experience. And once again, for that, I remember you that you need for that a neuropelveologist, ISO certified level 3, with at least 5 years, 10 years experience for this extremely difficult procedure. So I thank you very much. I hope I was able to give you some clarification about the situation with the pathology of the pudendal nerve. And once again, thank you very much to listen my lecture. And for the future, suppose you have some question, some point you would like to have clarification from the neuropelveological point of view, please let me know via Instagram or via a mail to our homepage www.possover.com. Thank you very much once again, and stay healthy. See you for the next education video. Thank you. Bye.